And yeah, one thing, um, only a couple of you have your cameras on. If you want to get participation points for the day, you got to be here and I got to actually see you. So please turn your cameras on, and I would just love to see your faces anyway. It's our last class. So yeah, there we go. Good to see you guys. Yeah, I know everybody's got, yeah, nobody wants to be back on Zoom. I get it. We've done this way too many times, but yeah, unfortunately, that's where we're at. So, couple of things before we get started on a brief review.
It didn't take me long, but that was because I knew I had a lot of storage. Now I know I don't.
Kindle there we go. Yeah, just make sure you're muted, guys, when you come in. And yeah, and then just a couple things. So yeah, the exam will still be in person on Wednesday. The final exam will. We will I'll have somebody there to proctor it. I'm not yeah, it's most likely going to be our department assistant in kinesiology, Tara Bowles. I'm not 100% sure yet, but that we'll have the exam at the normal time there in the classroom. So that's the plan. Again, if you have any honor lock issues or anything, like it seems to be that there's always a couple that do with each exam, your best resource is just hopping on their chat, on their tech support chat. That is the best way to go. Because yeah, I definitely don't know how to help you. Tara's not going to know how to help you, but they're pretty quick. I know a lot of you have had to do that when you have issues. So they're pretty helpful and pretty quick, and you have a full 2.5 hours for the final. It doesn't take that long. So don't let that stress you out. If you've got honor lock issues on Wednesday, just hop on the chat, try to get that figured out, and yeah, and then you can go from there. So yeah. So, and then as far as just two reminders today, you have two things due. So the last lecture quiz is due on by tonight, and that's just over the cardiovascular disease and diabetes stuff we talked about last time. And then also, if you haven't done your peer evaluations yet for your teammates, make sure you get those done by tonight, because those, by doing that, that's what gets you the points that your teammates assign to you. Okay, so if you don't do those, then you don't get any of the points that your teammates assign to you. All right, and then some of you had signed up for office hours this afternoon or Tuesday. I emailed all of you this morning about that. If you did, if you were one of those people that had signed up, but if you've signed up since then, or if you plan on signing up for Monday or Tuesday next week, I won't be able to be there in person. And so for security reasons with the exams, I don't actually like screen share and show you your exams on Zoom, but I'm happy to pull your exam up on a separate device and talk through which ones you might have got wrong or whatever, answer any questions you have on the content. I'm happy to do that. So I emailed you about that if you had already signed up, and just shoot me an email back and let me know if you still wanted to meet, because I know a lot of you were planning on not going to come unless you tell me otherwise. Okay, so let me know if you still want to come to that appointment, and then I will send you a Zoom link. Okay. Any questions about any of those things? Okay. All right, no questions? Nothing? Okay. All right, well, so what we'll do is, so I've got this big PowerPoint up here. I actually added it to Canvas. It's in the last module right next to where the final exam link is. It's got like 100 slides, a bunch of pretty much clicker questions that I threw together from a bunch of the notes from before. So it's nothing new. There's nothing new on this PowerPoint, but I did throw the PDF up there if you wanted to use it to quiz yourself. We definitely won't go through all of them right now, but we'll just hop through some topics, and then I'm also happy to answer any questions along the way that you might have. Okay. All right. So yeah, and the way we'll do most of these is just having you respond via the chat with an answer. So let's Yeah, let's start out with this one, discussing those muscle spindles and Golgi tendon organs. Okay, go ahead. Go ahead and give you a few, yeah, I'll give you 30 seconds or a minute or so to think about this one. And then I'll let you know when to go ahead and hit send on that chat. Not quite yet there. All right, go ahead and hit send when if you're ready. Yeah, so it looks pretty consistent there. Pretty much everybody's saying B and C. Okay, so let's take a look at that. Muscle spindles sense stretch. And remember with stretch, there's a component of length to this. So kind of telling us about the length of the muscle as well as the pulling on both sides. Golgi tendon organ senses tension. So that one is really dealing with contraction, trying to limit contraction of our muscle. And then when we stimulate the muscle spindle, that causes the muscle that was stretched to contract. So that does the opposite of stretching it, right? That shortens it. Okay. And then it inhibits the antagonist of that muscle. So we don't contract that antagonist and stretch our muscle that's being stretched more. Right. So, and then with the Golgi tendon organ, it's just the opposite of that. When we stimulate the Golgi tendon organ, that muscle that was contracting, that one gets inhibited. And then the antagonist of that one that was contracting contracts, right? So the actions are the exact opposite with the Golgi tendon organ reflex and the muscle spindle reflex. Okay, so this was some stuff from early on in the class, and I am, yeah, happy to answer any questions you have on the chat, or just feel free to unmute yourself at any point, and you can hop in there, and I'll be monitoring the chat as well as, yeah, feel free to unmute yourself. Okay, so any questions about that one so far? Okay. All right. Yeah, we kind of, this was from the whole taste section, right? So taste buds are more sensitive to alkaloids than they are acids, right? And that one is true because many poisons are alkaloid, right? Many, and even medications are this way. Most things like Tylenol and aspirin, all those types of things are very bitter, actually, and that's because they have a higher pH than neutral, and that tends to be the way poisons are. Okay, well, that's that one. Yeah, let's go ahead and think about this one for a second and send in your answer. I'll give you about 30 or 40 seconds. I'll tell you when to send it in. All right, go ahead and send that in if you're ready. Okay. Very consistent there. Everybody's saying C. So smell, the chemical will always start the second messenger system, which eventually leads to increased permeability of an ion, leading to an action potential. Okay. With taste, it can be either one, actually, right? Taste, it can be this one down here, not necessarily all, but chemicals can directly open an ion channel and lead to an action potential. Okay. Or it can be a second messenger system with taste. So either one. But yeah, the only correct answer there was C. Okay. Yeah, that one, I'm just gonna kind of skip some of these as we go and catch some of the other ones. Yeah, so that name for the delicious or savory taste, we talked about that one's going to be umami. Okay. Yeah, now you guys can see the answers to these. Sorry. Yeah, so yeah, which cranial nerve here is not involved in the taste sensation? Give you about 15 seconds to think about that one, and then I'll have you send in an answer. Not sure how many of you already saw that in my notes there or not, but All right, what you guys got? Yeah, so not quite sure. A lot of people saying B, but the right answer is actually C. So the vagus nerve is involved in it innervates the taste buds in the throat, right? So most of our taste buds are in the tongue. We only have some in the throat. So the vagus nerve is responsible for those ones in the throat. Okay, let's see what else here. Yeah, let's talk a little bit about vision here. Yeah, so go ahead and think about this one for a second. I'll have you send in an answer in just a few seconds. So up to 100 rods connect into one bipolar cell. It's typically only 1 to 3 cones connect to each bipolar cell. Okay, go ahead. Yeah, send it in whenever you're ready. Good, absolutely. Everybody is saying true there, A. And so this is why we get the clarity of vision that we do from our cones, because when light hits in a certain spot, stimulates a single cone, then the brain can very precisely interpret where that light hit on the retina, right? And it can piece together an image with with lots of precision. But when it's the rods, it could be anywhere along those 100 or so rods. It could have been any one of those that stimulated. So kind of that whole little area is just kind of blurry, right? So we don't get quite as much precision from that. And regarding that, the image or the stuff that we see is actually the light that yeah, definitely the objects don't necessarily emit light all the time, right? But the light from the sun or other sources that reflects off of the objects, that's really what we're seeing, right? Okay. Um, yeah, let's try one thing here. Let me see if I can do something here real quick. I'm going to put you in breakout rooms to discuss this one because this is an important one. And I would like for you to, yeah, discuss this whole process here, okay? And just kind of walk through the 3 things that need to happen when something is moving away from us, right? So we see what happens when things are moving towards us for near vision. This is the one you kind of have to fill in. Talk through both of those, but I'll give you a couple minutes in the breakout rooms to do that. Okay, so it's not going to be your teams. It's just going to be random. So okay, here we go. Yeah, so this yeah, so this is definitely an important piece of physiology from the early sections of this class, right? So when we're talking about things that are up close to us, those light rays are going to be divergent, meaning that they're coming out at very sharp angles, right? So we need to bend them a lot to be able to focus on them, be able to see them, right? So the lens needs to get more convex, right? It needs to get thicker. Okay, we do this by stimulating the oculomotor nerve, which contracts those ciliary muscles and lets the lens just elastically kind of come back to being more convex, right? The pupil then needs to constrict, so we block some of those divergent rays, right? So we contract the pupillary sphincter muscle. Again, that's with the oculomotor nerve, and so it blocks some of those really sharply bent rays and only allows the more parallel ones to get in. And then the eyeballs turn medially, right? We contract those medial recti muscles and they converge, the eyeballs converge and medially. Okay, so that was the one that you had there. For the fill-in one, when something is far away from us, the light rays are definitely more parallel. They don't need as much bending. So the ciliary muscles can relax and then they pull outwards, tighten up those suspensory ligaments, flatten the lens out so it doesn't have as much focusing power to it, right? And then the pupils can dilate, and most likely it's going to be this first mechanism via less activation of the oculomotor nerve, and or if it's a sympathetic activation, then we can use that pupillary dilated muscle and just rip open the pupil, but most likely that's not going to be happening. Most likely just relaxing the pupillary sphincter muscle, and the pupil dilates. And then lastly, those eyeballs need to move outwards, right? Need to turn laterally. So we can keep the light focused on the fovea centralis. That's why they're moving, right? So we can make sure that light's hitting the cones. And so they're going to diverge, going to move outwards. And we're going to use the lateral recti muscles for that, which is going to be abducens cranial nerve 6 for that. Okay, so definitely a key piece of physiology there and kind of process thing. Any questions on that one? Okay. All right. Definitely important to review this again. All these different little letters and kind of where certain damage, which kind of vision impairment people would have with each spot. Right. So we can do one example here. This one is peripheral vision. Peripheral vision is always going to be B, right? Because again, the light hitting the medial sides or the nasal sides of the retina, that light or the information is going to pass to the other side, right? But it goes through that optic chiasm right where B is, right? If we have damage at D, then that means we're getting the information from both here and over here. Let me change my color here real quick. And so that information in blue here is going to cross over to D, but then this information from the left eye and the lateral side is going to cross over to, or going to stay over there in D as well, right? So that is going to be our right field of vision. Whereas C is going to be our left field of vision, right? A would just be everything from the left eye, right? And then E would just be everything from the right eye. Okay, so just kind of different options there of places you can have damage and just trying to understand what kind of vision impairment you would have with each one. Okay, questions on those? Okay, yeah, let me see what we'll take a look at next here. Yeah, we kind of already talked about that. Definitely important. A lot of people get confused with these terms a little bit. So go ahead and think about this one for about 30 seconds, and I'll have you send the answer in on the chat here in just a sec. Yeah, go ahead, send it in when you're ready. Good. So pretty much everybody is saying C, which is good. So cholinergic, right? So acetylcholine, okay? Cholinergic, right? We see adrenaline, right? That's from adrenaline, right? Which is also epinephrine, right? So anytime we see adrenergic, we know we're talking about the sympathetic nervous system or the SNS, right? And anytime we see acetylcholine or a cholinergic receptor on the target tissue, right, then we know we're talking about the parasympathetic nervous system. Okay, so just knowing that right there, that can help you a lot with a lot of the questions that have clinical applications to them, like this drug blocks a cholinergic receptor in the eye, right? If it blocks a cholinergic receptor in the eye, it's going to kind of have the opposite effect of what would happen when the parasympathetic nervous system acts on the eye, right? Something that blocks the parasympathetic nervous system in the eye is going to dilate the pupil, right? That was that atropine drug that we talked about that the optometrist will put into your eye to make your pupils dilate. Okay, so but just knowing that basic terminology of these receptor types gives you the ability to answer those questions. Okay, questions on any?
Doctors?
Yes,
Okay.
go ahead, Lucia.
Do the like adrenergic receptors, I don't remember, was it the nicotinic one that's at the like after the preganglion? Don't those release acetylcholine as well, and then they release their norepinephrine or epinephrine?
Yeah, so on the sympathetic nervous system side, the preganglionic, we'll say preganglionic, that one releases acetylcholine, okay? But then from there you have a postganglionic, and that's why I was saying it's at the target tissue. We always have adrenergic. And pretty much all drugs, act at the target tissue, not here in the ganglion, right? So the drugs are going to be blocking that final receptor with the very end of the chain there. So, but yes, you're right. So you have acetylcholine receptors in the sympathetic nervous system, but only in that ganglion part from between preganglionic neuron and postganglionic neuron. And then when we get to the target tissue, it's always going to be adrenergic receptors. That makes sense? Okay. Yeah, and then another good point. That terminology nicotinic or muscarinic, right? That is only going to be referring to cholinergic, right? Those go together, but we would never say nicotinic adrenergic. It's just not a thing. Okay. We would never say muscarinic adrenergic. It's not a thing. Okay. Muscarinic and nicotinic only apply to the cholinergic one. Okay. And then we might see a prefix on the adrenergic one of either alpha or beta. I don't have you memorize any of the differences there for this class, like which ones would be alpha, which ones would be beta. But that would be the only prefix that you would see in front of an adrenergic one would be alpha or beta, and those can have numbers to them as well, but we don't get into all that in this class. Okay. Any more questions on those? Okay. I can also pause for a second, and I'm happy to address any specific questions that somebody had too, that outside of this, but I'll just keep that in your mind. If anybody does have a question that they wanted to get answered, I'm happy to do that. Or even just like a certain thing you wanted me to cover, I'm happy to do that as well. So you can put that in the chat or unmute yourself and tell me if you want. Go ahead. Go ahead, Daphne.
I was wondering, Professor Sawyer, if you can, I know we just went over this, but with the peripheral vision, because so is peripheral vision just like seeing something like on the side, but you're not looking directly at it. So then that's what's gonna hit the nasal, I think is what it's called, receptors.
Exactly. Yeah. Let's see. Let me do it again here. Let me erase some of this stuff so we can see it a little bit better. Yeah. So if we've got looking at something out here, right, and out here at the same time, so we're looking forward, but we can still see the stuff out here. If I put my hands out here, I can kind of still see it even though I'm looking forward. So the light from those things is really going to hit here and here for the most part. Yeah, sure, some of this light will hit over here, but not too much, right? So most of the light for the peripheral vision hits only on the medial side of our retinas. So all of that is going to cross over here at the optic chiasm. And that's why a pituitary tumor that sits right above the optic chiasm and pushes on that leads to tunnel vision. You lose that ability to see, see peripherally.
Okay, thank you.
Yeah, for sure. Yeah, it looks, Ashley asked a question there, diabetes and pre-glucose levels. Yeah, let's see. So the big thing with diagnosis, I don't know if I have that in this slide here. I think I do have those numbers here. Are you wondering about the actual numbers, Ashley? Yeah. Yeah, so the fasting glucose, so there's two ways to diagnose diabetes. Fasting glucose of greater than 126, that's diabetes. And then pre-diabetes is 100 to, 126, 100 to below 126. That's the pre-diabetes diagnosis, whereas diabetes is anything above 126. And then I believe, testing myself without having the notes there, but the hemoglobin A1C one is greater than 6.5%. And then pre is between 6 and 6.5%. Maybe somebody that has their notepad open there can just verify that I am remembering that right, but I'm pretty sure that's right. Is that what you're wondering about, Ashley? Okay. If anybody sees that was wrong on the hemoglobin A1C one, let us know, but I think that's right. Okay, let's talk a little bit about the hormones. Hormones are obviously a big section of the early part of this class. And yeah, and so remember, as before, you don't need to memorize all of these hypothalamic ones, but I did want you to at least know the full pathway with the thyroid hormones, which is TRH, right? So TRH goes to the anterior pituitary, and then that releases TSH, that goes to the thyroid glands, and then that thyroid gland, and then that releases T3 and T4, and then that has all the effects of the of the thyroid hormones. Okay, so that's that one. All the other ones have those pathways as well, but you only need to know from here down. You do need to know that yes, there was a hypothalamic hormone above that, and then that led to the release of one of these, right? And then that either has an action itself, like growth hormone, or it goes to another gland and causes another thing to be released. Okay. Yeah, one thing, definitely want to review the menstrual cycle and all those steps involved in there. Okay. We we kind of went through this whole slide very closely in class. And so the biggest things you want to understand are kind of what is happening
Oh,
both.
you got lucky. I wasn't gonna be able to
Tell who's unmuted there.
leave.
Weird that. Oh, that's Michaela. I'm gonna mute you. Cat. Okay. Yeah. So the big thing you want to be able to tell here is what's going on in the uterus and what's going on in the follicle with each stage. Okay. Those are going to be the key things. What do we see as far as hormone levels with each of those? Okay. Yeah. And so we can kind of trace that to what's going on here too in the in this hormone chart, right? So GnRH is a hypothalamic hormone. You don't necessarily need to know the name of. That's going to lead to the release of FSH and LH from the anterior pituitary. FSH and LH, there we see those. Okay, so FSH is causing growth of the follicle, right? That's what it's called, follicle stimulated hormone. So it makes the cells around the egg get bigger and bigger and bigger, right? And then that LH stimulates those cells to release androgens, and then those androgens get converted into estrogens, right? And so then that's how we produce more estrogen. And so the bigger and bigger and bigger that follicle gets, once we get over here to the stage leading right up to ovulation, right? So we're in that proliferative stage of the menstrual cycle, all the way up to ovulation, where it gets the follicle gets as big as it's going to get. Since all of these cells are the ones releasing estrogen, the more of them we have and the bigger it gets, the more estrogen is released. And then at some point that estrogen, instead of being negative feedback like we had over here, flips to positive feedback, right? And then we get this big surge of both LH and FSH, but the important one is the surge in LH, right? That surge in LH, that's where it's going to get its name, is because it luteinizes the follicle, right? It turns the follicle into the corpus luteum, causes ovulation. And so that's right leading up to that ovulation stage. And then the next 2 weeks of the menstrual cycle after ovulation can be looked at as the secretory phase if we're talking about the uterus, or it can be called the luteal phase if we're talking about the follicle, right? And so during that phase, that's where we get the most progesterone release, also some estrogens and some inhibins. But now we're back to those hormones providing negative feedback to the release of LH and FSH. And that corpus luteum is helping to keep the endometrium alive in case implantation happens during that phase. Okay, and then we'll kind of get back to the menstrual phase when this corpus luteum dies after about 2 weeks, if no implantation happened. Then the progesterone and estrogen levels drop, which leads to the endometrium dying and the sloughing off of the endometrium, which is what produces the menstrual bleeding. Okay, so definitely want to review that. This kind of walks you through that, but definitely get into those slides previously. Okay. Other questions about that or other things surrounding hormones that you wanted me to answer? All right, so we just went into this last time, but definitely make sure you're understanding that the hyperglycemia, and I don't know if I really ever defined these terms, but let me define those properly for us. Hyper is always going to mean like a lot of something, right? So hyperglycemia means high blood sugar, right? High blood glucose. Okay, but then we can also have hypoglycemia, which is just the opposite. That's going to be low glucose. Okay, but the hyperglycemia that characterizes type 2 diabetes is caused by 3 separate factors, right? We talked about those last time. It's not just decreased glucose uptake, which is related to insulin resistance. That is the primary factor. But then it's also that our pancreas also is not working that well. Our beta cells aren't producing enough insulin, and we're making too much glucose in the liver, and the liver is releasing too much glucose. And that's the third factor. Okay, so we got those 3 factors involved in impaired glucose tolerance or hyperglycemia that we see in type 2 diabetes. Okay, let's jump here for a sec, right? These 2 slides. So we went through this as well. So these are definitely key things to know. You definitely want to be familiar with this progression of atherosclerosis. Okay, and I think it's helpful to look at this image and kind of walk yourself through what's going on by relating it back to the words on this slide and understanding kind of this buildup, starting with just the endothelial cells not working properly, to eventually lots of inflammation, to then plaque buildup, to then that plaque getting so big that it gets its own blood supply and then can rupture, and then finally that rupture of the plaque leading to a clot in the blood vessel that can eventually get stuck somewhere and cause a heart attack or a stroke. Okay, questions on that?
Professor Sawyer,
Yeah,
can you explain what exactly angiogenesis is again?
yeah, angiogenesis is just new blood vessel formation. So genesis always just is referring to, making something new, right? And then angio is referring to blood vessels. So it just means making new blood vessels. So even though we're kind of talking about a blood vessel, right? We are talking about a blood vessel. We're talking about the plaque that builds up in this like lining of the blood vessel. It's like in the wall here, right? When that gets big enough, it actually starts kind of calling for its own blood supply, and the body starts trying to feed it blood because it's so big. But when it does that, it becomes more likely to break off and then lead to that clot, which could eventually lead to heart attack or stroke.
Thank you.
Yeah. And yeah, anything else on that stuff? Okay. Yeah, definitely make sure you're reviewing this stuff here on these integrated responses, right? So that we talked about when Sophie was teaching. There's really 2 groups of disturbances that we could be trying to deal with, right? So if it's too much salt, not enough water, right? And so then how we deal with that would be increase ADH, because that helps us pull in more water, and decrease renin, because that's going to decrease aldosterone, which then helps us actually get rid of some sodium. Salt, so we decrease our ADH and we increase our renin, and so that decrease in ADH helps us shed some water. The increase in renin helps us hold on to some sodium, so we can balance out that issue. In the body, right? That's the other set of problems. If we've got too much blood volume, and this happens in cases of heart failure, for example. People with heart failure have too much fluid in their heart, and that some of that fluid backs up in their lungs, and we get swelling. And so what we end up doing there is we want to decrease ADH, because that helps us shed water. We want to decrease renin, because that helps us shed sodium. We want to decrease sympathetic tone because that's going to open up the afferent arteriole and that's going to increase urine production, right? So that helps us shed water too. And then finally, we're going to increase this ANP, this natriuretic peptide one. And that one pretty much just does the opposite of everything else, right? It blocks ADH, it blocks renin, blocks the sympathetic nervous system, and it leads to us shedding more water and salt as well. Okay, and then that last one is just the opposite of that we just went through. If we don't have enough volume, then we need to decrease ANP, but increase all of these other ones so we can hold on to more fluid and salt. Okay. All right, questions around that or around the kidneys that anybody wanted to ask? Okay, definitely good to review these acidosis and alkalosis ones that we talked about recently in class, right? So respiratory and metabolic acidosis, respiratory and metabolic alkalosis, definitely just want to know the common causes of those. And then very key in understanding like what does the body do to compensate for each of those problems, right? It's 4 different problems there: respiratory alkalosis and acidosis, metabolic alkalosis and acidosis. Okay, let's see. Feel free to hit me with any other questions as I'm trying to decide what would be best to talk about here. Yeah, so some stuff with the heart. Definitely a big chunk was understanding cardiac output. When we talk about cardiac output, the equation for that, right? We got stroke volume times heart rate, right? So stroke volume is how much blood comes out with each beat. Heart rate is how many beats per minute, right? And then we talked about those 3 factors underneath stroke volume. So this is that equation there, right? Cardiac output is a product of which 2 variables. So that's going to be heart rate and stroke volume, okay? But then when we talked about stroke volume, we talked about 3 factors that dictate stroke volume. So we have preload, afterload, and contractility. Right, preload is going to be best defined or measured by end diastolic volume, right? That's how much blood is in the left ventricle before contraction, right at the end of rest. Afterload is best measured by our mean arterial pressure. That's how much blood pressure the left ventricle has to overcome to open up that aortic valve on the to get blood out, right? So that's really all about blood pressure. And then contractility was best measured by ejection fraction, right? And that's really just like the percentage of the blood that comes out when we pump it, right? Whatever amount of blood we started with. So we take the amount of blood that we got out, which is stroke volume. So I'll just put it here, the equation for ejection fraction is stroke volume over end diastolic volume times 100%, right? Because we're looking at stroke volume, which is what came out, and dividing that by what we started with, which is end diastolic volume. So we're just seeing like kind of a percentage of the blood that we started with that came out, right? And that's a very good measure of how hard the heart is contracting, which is what contractility is. Okay, so when we start exercising, we want to increase cardiac output. We increase preload, right? By getting more blood back to the heart, okay? We also increase contractility. That one's by the sympathetic nervous system. That makes our heart contract harder, okay? And then afterload is also going to increase, but this one actually doesn't help us, right? When that afterload increases, it just does because our blood pressure has to increase in order to get more, to get blood moving around the body faster. But that does make it a little bit harder to get that blood out of the heart. So this one's not necessarily helping us increase our, directly helping us increase our cardiac output or our stroke volume, but these 2 are. Right, the other key thing that we talked about, ejection fraction is going to increase, but then there's another variable we looked at here called end systolic volume, And when contractility increases, we can tell that another way to tell that besides ejection fraction going up is by end systolic volume going down, right? Meaning that there's less blood left over in the heart after that heart contracts, right? Because the heart got emptied more because we contracted it harder. Okay, remember that stroke volume equals end diastolic volume minus end systolic volume. Right, it's the amount of blood we started with in the heart, and then we subtract the amount that's left over, and that tells us what came out, right? And that's what stroke volume is. Okay. Yeah, questions around any of that stuff? Okay, let's see what else we should hit here. Any other questions as I'm looking?
Professor Sawyer,
Yeah.
can you go over the electrical properties of the heart again?
Yeah. I really have a good slide on that on this set of notes. Yeah, let me pull up. Yeah, let me just do this. So one of the, are you specifically referring to the action potential part? Is that what you're thinking of, Danica?
Yeah, like the action potentials and the SA nodes.
Yeah, yeah. So we have two areas of the heart that are autorhythmic for the most part, right? The sinoatrial node and the AV node, right? And if we look at the normal skeletal muscle action potential, it's going to look something like this, right? Okay, so that's kind of a normal one that would be for our skeletal muscle and for our neurons, right? We know that this depolarization is caused by sodium. This repolarization is caused by potassium. Say potassium out, sodium in, and then the hyperpolarization is also caused by potassium out. Okay, that's the normal one. But then when we look at a cardiac action potential, it's going to be much bigger. It's going to be flat. It's going to go straight up like this, a little bit drop down. It's got this big plateau phase, and then finally get back down here. Okay, so this is still going to be sodium in here. This plateau phase is going to be by calcium coming in, and then repolarization is going to be by potassium going out. Okay, so that's cardiac muscle. Right, when it comes to those autorhythmic cells, those are going to be a little bit different again. So we're going to see this kind of up, back down. That's not really that sharp. Then it comes back up, kind of more flat or rounded like that. There we go, something kind of more like this. Right. So yeah, let's not look at that one. So here we have this part right here is based on sodium influx. And so that's kind of the part that's just always leaking, right? We're always leaking some sodium into these cells. There's no flat period in here, right? There's no real resting membrane potential, because as soon as we get back down to repolarized, then the sodium channels open up again. We just start leaking in sodium. And then right about here, with that sodium leakage, that leads to calcium channels opening. And that's going to lead to calcium rushing in for that faster depolarization part. And then again, we still have potassium coming out for repolarization. So this is the autorhythmic cells. Sorry, that's a really bad handwriting. So autorhythmic cells there for that. That's this one. Cardiac muscle there for that one. And then a kind of our normal type of action potential there. Okay, good question, Danica.
Yeah, and then I was also wondering, because you said that one of the differences from skeletal muscle and cardiac muscle is that the sarcoplasmic reticulum, I think is what it was, enters the sarcomere once. I'm just like,
Yeah.
Can you explain that a bit more?
Yeah, there's nothing really too complex about it. The bottom line is that in heart muscle, we have to rely on extracellular calcium, a little bit. So we have to actually let calcium come in from the outside to help us contract the muscle fully. Whereas in skeletal muscle, there's just a much more developed sarcoplasmic reticulum that holds more calcium, it can release more faster. And so we don't need to rely on extracellular calcium. So we can just get a bunch of calcium released super quick with skeletal muscle. With cardiac muscle, it takes a while. But again, that's how we get this plateau phase right here, is because calcium's slowly rushing in, right? And the graph in your notes shows tension. Here, I'm going to change my colors. Shows tension on this line. So tension peaking out about right here in the heart, right? This would be tension. And the key in understanding that is, why does tension rise at the same time that calcium is flowing in? It's because calcium isn't just going in to depolarize or keep the cell depolarized. It's also going in there and then binding to troponin, which then allows us to get one more myosin head that attaches to actin, right? And every new myosin head that attaches to actin, we get some more force, right? Because that's the cause of our force production. So those are that's the key part about that, really. The part about it once or twice, don't worry too much about that. The bottom line is we get more calcium into skeletal muscle quicker, and in the heart we have to rely on it coming from the outside, and then we get that big plateau phase where it's rushing in and it binds to troponin, so we get more force out of that contraction.
Thank you.
Yeah.
Professor,
Uh-huh.
sorry, I wanted to ask some clarification. So on the study guide for this section,
Yeah.
you said know the details of how the action potentials occur in cardiac muscle cells. So do you just want us to know the details for cardiac muscle, or should we cover all three of these? So I was just
this one is really just review, right? We didn't really talk about this one too much last semester, the skeletal muscle one. But it is good to just kind of know, like, be able to kind of contrast it, know how it's different. But by saying cardiac muscle, I do really mean both of these, the two types of cardiac muscle, one, because autorhythmic cells are cardiac muscle too, but I do mean both of those. Yeah. Good question.
okay, thank you.
Yeah. Okay, what else? Let's see, I guess we've only got a couple minutes left. Let's see if there's anything else here that wanted to hit on. Yeah, you definitely want to make sure you're, understanding all the parts of the nephron well, as well as, what happens at each part of the nephron, like we went through in the notes, right? Definitely making sure you're understanding this juxtaglomerular apparatus, right, which includes these macular densus cells and these granular cells. And we're monitoring both solute concentration in the filtrate as well as blood pressure in that afferent arterial. Countercurrent multiplier mechanism. We talked about these things. What else? And I think you guys saw my notes. I used to make you calculate this renal clearance thing, and so that's why that was like a holdover in the study guide that I forgot to delete. You don't have to know that equation and calculate it, but you just need to know, if I give you GFR and I give you a number for renal clearance, you have to be able to compare that. If it's greater than renal or greater than GFR, it means something. If it's the same or if it's less, right? There are those three different scenarios for that. So these are the scenarios. So you want to know what some examples are of those scenarios and what that would mean. Okay. Well, I think we're about done. So let me just wrap it up here with just a couple comments here. This was our one of the first slides of the very first class last semester. And if you had me, I was over in Liberty Station. And this is kind of just a nice framing thing for me always, that in this class, we really look at everything starting at the very chemical level, right? We look at how those chemicals come together to make cells for us like this, right? And then we look at how those cells come together to make tissues for us, right? We look at how those tissues come together to then make organs. Look at how those organs come together to make organ systems, like we've been doing a lot this semester. And then we look at the organ system, and there's really there's no better example of this than what we did on Wednesday. We looked at diabetes and cardiovascular disease, and we looked at how one disease affected the whole organism, right? We looked at it affected everything that we had talked about over the course of the semester. And so, yeah, I hope you kind of, can work. So a few things that I'd love for you to take home with you. Number one, hopefully tons of foundational knowledge, right? Lots of stuff that you're going to build on. You're going to add to this with more clinical and practical knowledge as you move forward in your field. But now you've got a foundation to build on, right? And that's what this class is all about. You're not going to remember every single little bit of information from this class, but next time you learn about the kidneys, you're going to be familiar with it, right? You might have forgotten everything that happens in the proximal and distal tubule, but you're going to be familiar with it, right? So you can build on that. I really hope you got some sense of awe in God's creation, in all the different things that we studied, because there's so much, so many beautiful and wonderful things in his creation that we got to experience this semester in studying the human body. One of the things I think can be most important is that I hope you're excited about learning about how the body works. You probably already were. I hope maybe even got a little bit more excited, and hopefully there's some kind of fire lit in you to keep learning, because that's what it's all about, right? When you go into a new situation, you deal with a new patient, everybody's different. Everything's going to be slightly changed, different in each person. But if you're excited about learning, you want to really, you hunger for understanding of what's going on, then you're going to be a better practitioner, right? You're going to be a better practitioner of whatever that might be with the human body, if you really want to learn it because you're just passionate about learning. Right? So I hope you got a little bit of that. And then the thing I'd love to just say to you personally is, there's so many things that we use to kind of define ourselves in our life, right? Maybe it's our grade in this class, right? Maybe it's our grade in chemistry. Maybe it's how our friends perceive us. Maybe it's so many different things that in different times of our lives, we kind of lean on as things to prop us up and give us our identity, right? But what I want you to know, and I hope you know this, and I kind of started out the first day of class last semester with this as well, is that you're made in God's image, right? And you're exactly how he wanted you to be, because he designed you that way, right? And so the bottom line is you have inherent value, no matter how you perform, who you're friends with, all these other things that we use to define ourselves. So so that's that one. And this one, I definitely am sad to not be face to face with you guys for this class, and then for Wednesday as well, because it's my last time to see a lot of you guys. So please don't be a stranger. Come by and say hi to me. If you got a couple more years here at Point Loma, 2 or 3 more years or so, then then definitely check in. I would love to hear how it's going, hear how you're doing. I'll probably run into you on Kathleen at some point as well. And sometimes it takes about 30 seconds for me to pull your name up in my brain. So if I pause for a minute, that's why I do that. But yeah, so it's been a good semester with you guys and a good year and with a lot of you guys. So study hard and do well in the test, and have a wonderful summer, guys.
Thank you.
Thank you so much.
Dr. Sawyer.
Thank you.
Thank you.
Dr. Sawyer, thank you.
Thank you. Bye.
Bye.
Thank you. I hope you don't feel sick.
Thank you. I did a little bit, not too bad.
I hope you feel better.
Thank you.